Okay, yeah.
Yeah, sir, lives all around. Just give me a second now.
Yeah, yeah, fine.
Sorry, sir.
Yeah.
We are live, sir.
Good evening and welcome to the expert crosstalk on Empagliflozin, multi-pronged, multifaceted, and multi-benefits. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which would bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to EMPEROR-HF trial, does SGLT2 inhibitor an important drug for HFrEF? First, let me introduce today's speakers. Today's speakers are Dr. Rishi, Bhargav, Dr. Awesh Shingare, and I am your moderator, Dr. Shavi. Dr. Awesh is a consultant endocrinologist at MGM New Bombay Hospital, SL Raheja Hospital in Mumbai. Dr. Awesh has several national and international publications in his credit and also a speaker in various conferences and CMEs. I welcome Dr. Awesh in this expert web talk. Our next speaker is Dr. Rishi Bhargava. Dr. Rishi Bhargava is a consultant intervention cardiologist at NGN Hospital in Navi Mumbai and also in Medicity Hospital, Asha Hospital, and Mangal Prabhu Hospital in Maharashtra. Dr. Rishi has several national and international publications in his credit and also a co-investigator of various trials. I welcome Dr. Rishi in this expert web talk and I hand over the session to Dr. Awesh to start with the presentation. Thank you.
Yeah, yeah. Thank you very much. Thank you for
Yeah.
kind introduction. And good evening, everyone. Thank you for joining this evening. Good evening, Dr. Rishi. I'll start my talk. Just a minute. I'll just share the screen. Just a
Yeah.
minute. Just a minute. Yeah. Okay. So, topic for today is empagliflozin, multi-pronged, multifaceted, and multi-benefits. And the very fact that it's multiple benefits are often can be seen because we have two speakers. So it's not limited to endocrinology or diabetes. There are multiple cardiological benefits as well. And so both of us are here, and both of us will explain you why this is so, and in a respective field how beneficial this molecule is. So it's not limited only to diabetes. And so I will be talking on the endocrine or the diabetes perspective. And as you know, there are four different SGLT2 inhibitors available with us: dapagliflozin, remogliflozin, canagliflozin, and empagliflozin. And they are launched approximately. They are, all of them are available. Let's see how it is now. Now, coming to the basics, physiology or the mechanism of action. More than 180 gram per day of glucose is filtered by the kidney daily, and most of it is reabsorbed. So that's the mechanism. Only if the blood glucose crosses a particular threshold, usually it is more than 180, then we can see that there is a glycosyluria. That means that the kidney failed to excrete all the filtered glucose, and it goes away through the urine. There was initially a family which was studied, and in which there was what was seen, that the renal threshold was for glucose was very low. That means even at 100 or 80 gram of blood glucose, they used to have glycosuria. And interesting thing in that family was, apart from glycosuria, there was no other problem with that family or that group of patients. And another thing, they were very resistant to diabetes or the metabolic abnormalities. With this led to the stimulation of scientific knowledge ki why this is happening. And then they studied and found out there is something called as SGLT2, that is that is a glucose transporter in the kidney, and there is a defect in that. So that led to the further studies, and then SGLT2 inhibitors were developed based on that evidence or that background. And since that family already was kind of natural what we say means to show what SGLT2 defect or SGLT2 inhibition can do, eventually in other diabetic patients or other patients also, this SGLT2 inhibitor showed a very classical or very good effects. And that's why today no doubt that they are one of the top foremost agent. And even if you can say uh, frontline, or if not frontline, at least after metformin, they are the SGLT2 inhibitors are there. So coming to the three main drugs which are available to us, which are empagliflozin, dapagliflozin, and canagliflozin. The therapeutic dose you can see for empagliflozin is 10 to 25 milligram per day. All of them are administered with or without food. Canagliflozin is before first meal, and the important aspect is most of them are given in the morning. The reason is with glycosuria there is some amount of diuresis, and it's the same thing as why we give diuretics in morning, because there will be some frequent urination observed. It's better to keep it in the morning time only. So that's the whole reason that most of the thing the preferred dosing is in morning. Metabolism wise, it's primarily glucuronidation, no active metabolite, and partly eliminated to hepatic, partly through renal. Now, selectivity over SGLT1 inhibitor, empagliflozin, as you can see, is quite selective. That means it's more specific for SGLT2, and there is less of cross reactivity with SGLT1. Now, if you see recently, the dual SGLT are under studied. So they are like which can inhibit both SGLT1 and 2. But this is not the topic for today, and they still are in the research purpose. But as you can see here, selectivity over SGLT1 is more for MPIs. It is more specific. High and what about the glucose excretion? So if a patient has a high this thing high glucose and in maximum dose, even up to 78 to 80 gram per day is excreted. Now remember, this excretion is irrespective of the blood sugar. That means it raises the threshold, and it decreases the threshold. That is, even at lower sugar the glucose is excreted, but the fact that it never, the threshold never reaches up to 80 or 70, and so that there are very minimally prone to hypoglycemia. That's the that's the good thing about it. Unlike other anti-diabetics which are available, like they will keep on stimulating insulin secretion, and then patient is more prone for hypoglycemia in other anti-diabetics. So after the brief mechanism and all, what about the evidence? What the evidence say? Yes, we have evidence, and in the phase 3 study, sorry, yeah, in the phase 3 study, as you can say, the placebo control study, the change in HbA1c was studied compared to the baseline. And as you can see, once if it was used as a monotherapy, the A1c decrease with 10 milligram was up to minus decrease was 0.74, and from empagliflozin 25 milligram the decrease was 0.85. So a good A1c decrease was seen from baseline by both the dosage, that is 10 and 25. And remember, most of the anti-diabetics, say for matter gliptins or others, usually have this kind of this thing, the A1c decrease in the range of 0.8 etc. So this keeps in line with that, except for insulin and metformin, which are the highest A1c decrease. So a good, reasonably good A1c decrease was seen. But what when it was combined with other medicines, even after combination, over and above the baseline, there was a significant A1c decrease which was seen. So you can see with after metformin, it was 0.57 and 0.64, with EMPA 10 and 25 respectively, with pioglitazone with sulfonylurea plus metformin. Even after addition to insulin, the significant A1c decrease of almost 0.5 and 0.6 decrease is seen. So pooled together, taken all this together, with 10 milligram, we can say A1c decrease of 0.6, and with 25 A1c decrease of almost 0.7 is seen with this SGLT2 inhibitor empagliflozin. So this is a good A1c decrease, and this is what we want. So we'll come to the next slide. But remember, is it only the A1c decrease? The answer is no. There is far more to this molecule and to this drug apart from A1c decrease, and that we'll be seeing today. So, but coming first, we'll have to address the basic, because we are giving it to a diabetic patient. First, we covered the basic that A1C, yes, it is decreased significantly, irrespective of the prior treatment which patient is taking. Now, coming to the other benefit, that is the change in weight. Now, the problem with sulfonylurea, insulin was always with pioglitazone, the weight increases. The weight increases with metformin. The weight may decrease, may not, but it's considered weight neutral. But pioglitazone, sulfonylurea, insulin, always one of the main hindrance to their use was that they cause weight gain. And so empagliflozin in phase 3 study with 10 and 25, it is monotherapy. Look at the weight, this thing, the weight loss. It is almost 1.9 with 10 and 2.2. So roughly you can say 2 kg was seen with monotherapy. And even when it was added to any of the medicine, look, even if it was added to pioglitazone, there was a significant weight loss in the range of 2 kg. With sulfonylurea, almost same was seen. So this is like irrespective of the baseline medication use, or even in monotherapy, significant weight reduction was seen with this empagliflozin. So that's an added benefit. And remember, A1C is one aspect, but metabolic improvement is the matter of like need of the hour. And metabolic improvement like weight gain is seen with this empagliflozin. And that's not all. So that's just the beginning. We'll keep on seeing what are the improvements or what are the benefits in this molecule. Now coming to the next benefit about the change in blood pressure. So as you know, around 20 to 30% of diabetic will have sorry, not 20 to 30%, a significant number, almost 2/3 is quoted, will have some amount of blood pressure. And it's always good if that reduction in blood pressure can be achieved. And you can see here again with empagliflozin, when used as a monotherapy 10 and 25, a systolic blood pressure reduction of 2.5 to with 10 and almost 3.5 with 25 seen. So maybe debated, it may not be that significant, but yes, a reduction and some improvement in systolic blood pressure is seen. Similarly, when used as an add-on with any other molecule, even with pioglitazone, etc., you can see a significant amount of systolic blood pressure reduction is seen. Taken together, what we see is with 10 milligram, almost on an average 3.4 systolic millimeter systolic blood pressure reduction, and 3.8 mm of Hg systolic BP reduction with 25 milligram is seen. So together, what we can say, it's a good in this aspect also. There is a good improvement, and it scores above or rest all other anti-diabetic medicines. Now, what happens with a 12-week ambulatory monitoring of a patient with diabetes and hypertension, and where an hourly systolic blood pressure is recorded. So you see at the baseline here with placebo, the empagliflozin arm, and the this thing empagliflozin 10 milligram and 25 milligram arm. At baseline, the curves are almost same. So irrespective of the hour, during daytime the blood pressure is high, and at night there is a nocturnal drop. Here you can see the night blood pressure decreases at baseline. But once empagliflozin is started, in one group with 10, in one group with 25, what is the difference? So look at the placebo. The placebo arm remains the same. There is hardly any difference. But with 10 and 25, there is a reduction in blood pressure. And with both the groups, so that is empagliflozin 10 and 25, you can see a decrease in systolic blood pressure. Particularly, curve separation is prominent during the daytime. So in daytime, the reduction is between more, and at night, maybe that nocturnal drop is already there. So at night, the difference is not there. But still, a daytime reduction is there, and it has made a great benefit. It does makes a great benefit in terms of reducing the future complications. So this with this is a very good and positive effect of empagliflozin. Sorry, yeah. So similarly, this is the same curve, but this illustrates about the diastolic blood pressure at week 12. You can see similarly with placebo, there is hardly any decrease, but with both EMPA 10 and EMPA 25, you can see there is a decrease in blood pressure compared to placebo. This is about the And read this last point. This both the reduction in BP was not associated with increased pulse rate. So that's again and another. So they are not straining the heart, or they are not causing any tachycardia, which might prove to be detrimental. So pulse rate remains the same. Over and above it, you get a BP reduction in the range of 3 to 5 millimeter of Hg. That's a great favorable improvement. So taken together, we can see the effect of SGLT2 on glucose control, body weight, and systolic blood pressure we had seen in last 3 to 4 slide, and you can see that as a monotherapy and add-on also. I won't go. This is a busy slide, but just to summarize, taken together, they do reduce AGLT2 inhibitor do reduce the A1C, favorable effect on fasting blood glucose, the weight reduction almost in the range of 1.5 to 2 kg, and when added to other molecules, you can see up to 2 kg weight reduction, and there is a systolic blood pressure reduction also. Now this is for all the AGLT2 inhibitors combined, but with the data with empagliflozin is far better. As you have seen here, with monotherapy they are not commenting on the data but with empagliflozin we have the data of the BP reduction of 3 to 5 millimeter of Hg. Now, effects, benefits, you have seen the mechanism for seen, but what about the safety? The next question always comes: the safety. Is it safe? It's like the same thing that COVID vaccine is available now, and it's 95% efficacious. But the next question is always prompt: that is it safe? Am I going to take that mRNA or something in my body? So anyway, we are not here to discuss COVID vaccine, but what about empagliflozin, and is it safe? The answer is yes, it's absolutely safe. You can see what the number of adverse effect. There were few adverse effect with empagliflozin as well, but you can see compared to placebo, the adverse effect were almost same. There was not any significant difference with placebo. And so adverse effect in the sense any problems with patient develops during the course of study. So that doesn't mean that the drug is only the cause. It can be any other reason. So all are reported in the study, as the clinical trials are conducted very rigorously. All the adverse effect which patient pursues or develop during the course of study are reported, and compared to placebo you can see there is with 10 milligram it's almost same, and with 25 hardly any difference. So they're absolutely safe. What about the patient discontinuing? So about 5.6% you can see discontinued, and here also almost 5% to 5.3 discontinued. So no major discontinuation greater than the placebo. Coming to serious adverse effect compared to placebo, you can say almost again same. So, and deaths compared to placebo in fact were less. This is a unknown fact because they are known to decrease the CVD mortality. So in all other aspects, in all these aspects, in rigorously conducted trial, empagliflozin has shown its safety and tolerability also. So there is lesser discontinuation, lesser any kind of adverse effect or severe adverse effect. Now, clinically speaking, what about the safety issues? So, see, clinically speaking, the major importance or the major problem which we feel is urinary tract infection. That's the thing that might lead to any not. I won't call it as a safety concern, because urinary tract infection can be easily be treated. However, it is a minor side effect I will see, and it has to be recognized early. But remember, diabetics as such are prone to urinary tract infection, and there are various studies. Some studies shows that compared to a uncontrolled diabetes, the UTI with SGLT2 inhibitor is not more. Few studies have shown mild increase in UTI, but at the most it's almost roughly around 3 to 5%, not more, and it can be easily treated. So in day-to-day practice or clinical practice, this adverse effects or the clinical side effects is not a problem. Now, the, uh, the characteristic trial or the landmark trial of the empagliflozin, in which the cardiovascular outcomes in patients with type 2 diabetes and high cardiovascular risk were studied. Now, each SGLT2 inhibitor, or say for that matter, gliptins, has its own cardiovascular safety trial. In case of empagliflozin, it is the EMPARAGE, and we'll see what is the EMPARAGE outcome was there. Now, in this, firstly about the renal outcomes. So, in the EMPARAGE renal outcomes, compared with placebo, empagliflozin the worsening or the incidence, there is new onset nephropathy or worsening of nephropathy was comparatively less compared to placebo. So it is in the range of almost 60% reduction was seen. Progression to macroalbuminuria, again compared, this is placebo and this empagliflozin is less, and almost 60% hazard is, that is the 60% less likely to progress to macroalbuminuria with empagliflozin compared to placebo. And composite renal outcome is again the same, that is doubling of serum creat or worsening of nephropathy or progression to ESRD. So in renal parameters compared to placebo, it has clearly shown benefit, and it's clearly safe, or in fact it reduces the incidence or reduces the renal worsening. So patients with type 2 diabetes and high CV risk, given in addition to standard of care, empagliflozin reduces heart failure, hospitalization or CV death. And there is a benefit observed in both those with and without heart failure at baseline. So even if there is no heart failure at baseline, there is reduction in CVD events or the heart related events, and that's seen irrespective of the baseline heart failure. So renal we have already seen. CV will Dr. Rishi will also talk on this aspect, so I won't touch that, but cardiac benefits and cardiac safety is clearly seen with empagliflozin. Now the question comes, how early? So that does that mean today I will start empagliflozin, and the cardiac risk factors take around 10 years to develop, and after 10 years will that patient show the cardiac benefit? How early will be seen? The answer is it's seen very, very early. So if you see the separation of the curve begins to separate as early as 3 months. So what does that mean? So even after 3 months of empagliflozin, the benefits or the CV benefits or the cardiac benefits are seen. So it's not that one has to wait for 10 years for the cardiac thing to show its effect, and then after 10 years you will see that yes, in 10 years back which empagliflozin was started has shown benefit. Nothing like that. In a matter of say 3 months or so, there is a curve separation, and curve separation means the patients on placebo have more incidence of say heart failure, CV event, 3-point MACE, and patients who are empagliflozin clearly have a lesser incidence of these CV events. So this is as early these are seen, and so that's there, and benefits are seen in relation to hospitalization for heart failure, CV death, etc., and all the aspects. So the same thing is seen, how early it is seen, and you can see in this graph, even in first 100 days, or even the 100 days in the sense I told it's 3 months, roughly 90 days, you can see the benefits are clearly seen. Now, effectiveness and safety of empagliflozin in routine care patients. So as we have clearly seen in routine, this is like EMPARAGE trial is done in a clinical controlled trial setting, which is different. But what about the routine care patients? What about the daily thing? So this for daily patients or day-to-day activities, an EMPARAGE trial was there. We studied the patient in day-to-day findings, and the findings with EMPARAGE were almost similar with that. And in this, empagliflozin was compared with DPP-4 inhibitors, the other commonly used anti-diabetic. And you can see, compared to DPP-4 inhibitors, this is a lesser, there is a lesser things in myocardial infarction. There is ischemic or this thing, hemorrhagic stroke is less, all cause mortality is less. So you can see hospitalization for heart failure is less. So everything is lesser. This MI, ischemic or hemorrhagic stroke is crossing the this thing midline. That means it may not be this thing statistically significant, but definitely it's less compared to DPP-4 inhibitors in a real world setting. And hospitalization for heart failure and all cause mortality is definitely decreased by empagliflozin. So compared to other commonly used gliptins, it clearly shows an advantage. Now, yeah, this is a quick slide that each and every each and every anti-diabetic which is introduced after 2013 has its own cardiovascular safety trial, and the red thing denotes the cardiovascular safety trial of this thing SGLT2 inhibitors, and the blue ones for the gliptins. So gliptins will have their own trial of examine, severity, TCOS, etc. And in SGLT2, if you see, EMPA-REG outcome or empagliflozin COT was the first thing which was seen as early as in 2005. The results were 2015. Sorry, the results were published. Compared to that, all other SGLT2 are quite recently published. And interesting, it has shown a clear-cut benefit at that time, which other trials have just replicated. So, yeah. So coming to the last two aspects of the talk. Now, if you have seen all this, there is improvement in renal parameters, cardiac parameters, blood pressure reduction, weight reduction. Obviously, sugar is always. What exactly is how exactly they act? So, what SGLT2 inhibitors do is they decrease glucose and hence decrease insulin. That is one aspect, and glucose is excreted to kidney. The second thing is like there is also blood pressure reduction. And arterial stiffness reduction. The mechanism of this is simple. They reduce the afterload because they cause diuresis. Albuminuria is reduced because intrarenal hypertension or the intrarenal hypertension is decreased by decreasing the blood pressure and glycosuria. Uric acid also by means of diuresis it is reduced. Then they have a favorable effect on uh, by decreasing glucose and improving metabolic profile in favorable effect on this thing cholesterol and HDL and LDL. This is seen. Oxidative stress is decreased. Visceral adiposity. So if glucose is excreted, it brings a kind of catabolic state, or rather than catabolic state, it decreases, or the body melt down its own fat, and hence visceral adiposity is decreased. So all these are the beneficial effect, and these are the effects which have. This leads to the kind of pleiotropic or multiple benefits of the SGLT2 inhibitor. So the last slide. What about the all you have seen? You have seen the advantages. You have seen the benefits. You have seen the this what the this thing say. Uh, uh, yeah, what trial says and what evidence is there, but what guidelines say? Do experts or do experts agree? Do international body agree? Yeah, and the answer is yes, yes, and yes. Clearly, ADA and EAST, that is European Society, in 2018, they have clearly told that now lifestyle modification will be the first treatment. After that, it may not be metformin. So till decades ago, it was the metformin which we were treating. Not that metformin is knocked off or metformin we don't use. Metformin is still there, but what they mean to say, it need not be metformin. If patient, you see the patient first, and if patient has established ASCVD, that is atherosclerotic cardiovascular disease, or if he or she is high risk for that, you start with SGLT2 or GLP-1 receptor agonist. So SGLT2 inhibitors are clearly now kind of first line in this kind of patient who have established heart disease or which are high risk, and then you can consider metformin, or if not controlled. So this thing, that doesn't mean that in other group of patient you have to use metformin. Even in other group, if patient is diabetic but he doesn't have any cardiovascular risk factor, but if there are indications that you want to decrease his weight, or if he's more prone to hypoglycemia, in that case also SGLT2 inhibitors clearly have an advantage, because it causes weight reduction. It doesn't cause any hypoglycemia. The last part is, if patient has like mild CKD, or if patient is has this thing, if patient has mild CKD, or patient is has repeated hospitalization for heart failure, in that group again SGLT2 is clear cut advantage, because it reduces the future incidence of heart failure. So with this has been background, SGLT2 inhibitors have kindly means taken an important step in this group of patients. Is clearly after lifestyle modification they are indicated, but even in other diabetes they are clearly becoming more and more important, and with respect to that, they can be, if not, if you argue it not first line, second line and third line, they clearly have a chance, so clearly are being used. So with this, I will end my part on the diabetic things, diabetics perspective. Thank you very much. Thank you for patient listening. Yeah. Yes, I think Dr. Rishi will take over from here. Over to you, Dr. Rishi.
Yeah. Yeah, so good evening, everyone. Uh, I consider myself fortunate to be given opportunity to discuss about a very important molecule, empagliflozin. I think this is second most talked about pharmaceutical molecule right now. The first ones obviously are COVID-related molecules. So So diabetes is like one of the major killer in the world, and most of the cases happens because of the complications related to cardiovascular outcomes. So it was always a target to control sugar and be aggressive about that. But it was seen that that was not getting translated to the clinical benefit in the terms of mortality, benefits in the terms of reduction in heart failure or CV events. So there was some missing link which were soft after, and I think the answer we in fact started to found in the form of SGLT2 inhibitor. There are many more molecules, many more things to come, but SGLT2 inhibitor proves to be a very important link to have cardiovascular benefit in patients of diabetes. So as Dr. Awesh rightly mentioned that CVOT safety trials were like a norm about all the new molecules, new antidiabetic molecules. So these all new classes were tested for them, and it was found that they were not only safe with respect to CV outcomes. In fact, they were showing benefit over the placebo when compared with respect to CV outcomes. So the first important trial which was done with that outcome in mind was EMPA-REG outcome, and slowly the evidence started accumulating in the form of Canvas, Declare TIMI, Vertis, which was done with Empagliflozin, and also DAPA-HI, which is not mentioned here. So almost all the trials were found to have CV benefits in the form of decrease in heart failure, decrease in CV death, CV outcomes, and also were found to have renal events. So heart failure, cardiac outcomes, as well as renal outcomes, both were found to be reduced with these molecules. So these were the beauty of these molecules. So Dr. Awesh already mentioned in detail about the EMPA-REG outcome, but to again repeat, it has shown benefit over empagliflozin has shown benefit over placebo with respect to composite endpoint of CV death, heart failure, and renal outcomes and all-cause death. However, the outcome was driven primarily by CV death and heart failure hospitalizations. As you can see, there was significant difference in the incidence ratio. Now we'll be going back to understand how diabetes is mainly affecting the patients and with respect to cardiovascular events. So with the help of many trials conducted long back like Framingham Heart Studies or UKPDS, almost all the trials have shown that the incidence of heart failure or CV events are more in all the patients of diabetes as compared to patients who are not suffering from diabetes. So this high rate of heart failure was always a bothering factor in case of diabetes. Also, there were other events like cerebrovascular disorders, cardiac failure, then peripheral vascular disease and stroke, which were high in these patients. So if we take into account all the CV events, heart failure is always more common as compared to MI and stroke. The reason behind that may be the heart failure is there even when patient is not having acute event like MI, because the diabetic cardiomyopathy itself is something which is more common in them. Also, they are known to cause chronic coronary syndromes. So heart failure was always something which was focused in these trials, and while the anti-diabetic molecules were studied. As I mentioned that glycemic control was always the target, but it was not always getting translated into clinical benefits. It was shown more in these trials in which intensive versus not so intensive control of the sugar was studied. So the clinical benefits with respect to CV outcomes, what not much difference in both the groups. As you can see, the markers were close to the midpoint. So intensive or less intensive control of the diabetes was not defining any difference in the CV outcomes. So it proved that there is something which we are missing. That's why we needed more research, more studies, and some new molecules. So then come these SGLT2 inhibitors. The study which has brought them into the light were EMPA outcome, and which were further taken with the help of Canvas and DAPA-HF, Declare-TIMI, and Vertis-CV. So EMPA outcome provided a robust data with 7,000 patients. It has included all diabetic patients with high risk of developing ASCVD, and some of them, that is 10%, had heart failure to start with. And as Dr. Awesh mentioned, it went on to show significant benefit with respect to CV outcomes. The doses were used were 10 and 25 mg. So both have shown benefit. However, with respect to safety, the 10 mg proved to be better as compared to 25 mg. So I think this is just a repeat of what Dr. Awesh told, but I will want to insist here one thing. The CV death, if you see, the benefit with respect to CV death was significant as compared to MI, stroke, or the 3-point MACE. Also, it is important to know that empagliflozin is the only molecule amongst the SGLT inhibitors which has shown significant benefits with respect to CV death. So there is somewhat heterogeneity if CV death is concerned. If heart failure, hospitalizations, all cause death is concerned, it is a class effect. But with respect to CV death, empagliflozin is superior scores over the other molecules. Yes, the curves start separating very early. So within 3 months, the curve starts separating, and the benefit is consistent over 48 months. So, and even must be longer. So more data will be coming and we will come to know. As far as pathophysiological mechanism of how they are beneficial, as that is what we are discussing. They are like multi-pronged effects which are causing benefit in the CV outcomes. Like they are causing natriuresis, reduced preload, afterload, LV wall stress, improved kidney function, reduction in interstitial edema. Also, Dr. Awesh has mentioned the improved lipid profile, then improvement in BP, then adiposity. So all these factors coming together and providing benefit with respect to CV outcomes in these trials. So these all evidence made us to consider empagliflozin in patients who were actually sick with heart failure. With that, Emperor heart failure studies were done. We have Emperor reduced results out. Emperor preserved trial is still ongoing. Emperor reduced is about use of empagliflozin in patients of HF with reduced ejection fraction. Emperor preserved is still ongoing in patients with HF with preserved ejection fraction, that is LV ejection fraction more than 40%. So Emperor reduced was conducted in all over the world in many countries, and it was a trial design. So the important point with respect to Emperor reduced as compared to other trials in similar patients like DAPA-HF, that they have taken into study patients who are sicker. They had lesser ejection fraction, they had more anti-pro-BNP levels. So they have taken into account sicker patient. And why the study was done. So it was always in the mind with respect to these molecular effects that empagliflozin is going to increase fasting levels of ketone bodies, which are efficient fuel. Also, they have inhibition of sodium hydrogen exchanger, which actually increases stress to the myocytes by increasing sodium and calcium. So once this NHE1, that is sodium hydrogen exchanger 1, is suppressed, there is less of sodium and calcium intracellular, and that's why the myocardial function improves. And that's why it was anticipated that these agents can be of benefit in heart failure patients. With this in mind, the trial Emperor reduced was considered. So these were the speculated mechanism. Also, you can note there is evidence of reduced cardiac fibrosis. So separate studies were done, which were like molecular studies where LV mass index, LV strain, these all were taken into account, and it was found that these molecules shows benefit over placebo with respect to LV mass index and strain studies. This in mind, the trial was considered and presented recently in NEJM by notable speaker Milton Packer. So it has shown benefit with respect to primary outcome, secondary outcome, and secondary outcome. Those were all related to composite of CV death, heart failure, and all-cause mortality. So how that trial is important because there is established line of therapy, guideline directed medical therapy, which includes mineral corticoid antagonist, beta blocker, ACE inhibitor, ARBs, or ARNI. So this trial is going to put empagliflozin into the line of those drugs having proven mortality benefit in patients with reduced ejection fraction, that is EF less than 40%. So as I mentioned, it has compared empagliflozin 10 mg with placebo in patients of HF with reduced ejection fraction. Around 7,000 patients were screened for that. These were the inclusion criteria. As I mentioned, that those were the sicker patients. So LV ejection fraction as well as NT-proBNP both were taken into account. If there was concomitant atrial fibrillation, the threshold for NT-proBNP were doubled. It was because with arrhythmia in the form of atrial fibrillation, there is expected increase in the NT-proBNP. Very sick patients or patients with acute event actually were not included. However, I must tell their study is going on with respect to these patients also. So the patients included were baseline characteristic were similar in both the groups, placebo as well as EMPA group, and all ethnicity, almost all continents patients were included. It is important to note that patients who were included, majority of them were in NYHA class 2. So they are the patients who generally visit us in OPD. So this molecule is shown to be beneficial in them. There were lesser patients of class 3 or class 4, but the studies are ongoing and we expect them to be beneficial in them also. Most of them were on the guideline directed medical therapy. So as I mentioned, principal outcomes were CV death, HF hospitalization, or all-cause death. The empagliflozin has shown benefit over placebo, which was significant with respect to composite outcomes. So this is the summary of the EMPEROR reduced trial. Significant benefit with respect to CV death, CV event, heart failure hospitalization, and decline in GFR. So it has taken GFR more than 45, but some patients having GFR less than 30 were even benefited with this molecule. So there is increase in the time for the hospitalization with respect to the first event in patients having empagliflozin. Same with respect to CV death, heart failure hospitalization, or composite renal events. Renal event, as Dr. Awesh has mentioned, macroalbuminemia or the incident nephropathy. So it has major implication for clinical practice. It will be a necessary addition in patients who are already on GDMT but are not having significant benefit with the available therapy. And as the trial has shown, it can show benefit right from the beginning and can be an useful addition. So hospitalization for heart failure was significantly different. It is again mentioned with respect to placebo. As you can see, the difference is primarily driven by the hospitalization for heart failure. Yeah, so this is the summary of the trial. And as we can conclude that amongst patients who are receiving recommended therapy of HF, those in EMPA group had a lower risk of CV death, CV, or hospitalization heart failure than those in placebo group, irrespective of presence or absence of diabetes. This is an important point to note that patients who are non-diabetic were also benefited. Also, the adverse events like hypoglycemia were less, as the mechanism mentioned by Dr. Awesh about the glycosuria. The secondary endpoints like change in blood pressure, HbA1c reduction, change in weight, hypoglycemic events, all-cause mortality, everything was better in empagliflozin group as compared to placebo. So, coming to the interpretation of the trial, that trial Emperor reduced has shown that it is superior to placebo in improving HF outcomes among patients with symptomatic stable heart failure with reduced ejection fraction. Hemodynamically unstable patients, whether it shows benefit or not, the trial will prove. Then the benefit is mostly driven by HF hospitalization. Also benefit were there in renal outcomes, and the findings are in line with those published with dapagliflozin in DAPA-HF trial. It has shown benefit clearly irrespective of diabetes status, and it will be a useful addition in the future heart failure management. So guidelines have also come with addition of SGLT2 inhibitor in management of diabetes with heart failure patient, and it is considered to be an agent to start with or to add on very soon in the management of diabetic patient who are at risk of cardiovascular disease or are suffering from cardiovascular disease or heart failure. So with this, there are evolving research. So this is just a beginning. The research is going on with respect to preserved ejection fraction, with respect to patient with acute coronary syndrome, with respect to peripheral vascular diseases. So SGLT2 inhibitor, especially empagliflozin, may prove to be a wonderful molecule in future. Thank you.
Yeah, thank you for your wonderful presentation, sir. So there is a question from the audience. The question is like this. So after the Emperor-HF trial, if we compare empagliflozin with metformin, metformin is considered as a first-line drug for the diabetes. Okay, but sometimes it has been told that early initiation of empagliflozin will be better for the diabetic patient. So if we compare this metformin and empagliflozin, do you think empagliflozin may be a game changer in this case compared to the metformin? Means, what's your opinion? What's your practical experience like?
Yeah, so I think both diabetologists as well as me, we have our own perspective with respect to this.
Diabetologists, yes.
Yeah, so to start with cardiology point of view. Yeah, so it is like metformin was standard line of treatment for all the diabetic patients to start with. But as guidelines have come up with this available evidence, empagliflozin can be a game changer because of this multi-pronged, multifaceted effects. It is not only it is reducing sugar, HbA1c on top as compared to the other molecules, it is also showing benefit in incidence of heart failure, renal outcomes. So surely it is going to be a game changer, and I think it is the go-to molecule in diabetes.
Dr. Awesh, Dr. Awesh?
Yeah, so what I feel
Your
is,
opinion? Yeah.
I agree with Dr. Rishi. So it's going to be a game changer. But one view or is that metformin is available with us since a long time. It's not a 10 days, it's there since 3 to 4 decades. It comparatively cheap. That is what I, in other words, economical. And the A1C reduction with metformin is minus 1.5 to 2. So that does suggest there will be tough competition from metformin side also.
Yes. Yes.
And the time will tell. So as Dr. Rishi said that it has to be multifaceted management, which SGLT2 inhibitors, empagliflozin is clearly showing. But from my perspective, it's not easy to replace also. So it is a tough thing, and let's see. We'll enjoy the debates.
Yeah.
Yeah.
Thank you.
Yeah.
Thank you very much. There is no more question. So, with
Okay.
permission, can we stop the session, sir? We're concluding the session. Okay. Thank you, Dr. Awesh and Dr. Rishi, for your wonderful presentation, sharing your experience. And
Thanks for
thank you.
organizing this event. This was wonderful to focus on one particular molecule and discuss the available evidence. And it will be of use to all the practitioners all over. Thank you.
Yes. Thank you very much. And
Thank you.
future meetings.
Thank you very much. Thank you. Bye.
Bye.
Thank you.